Hi, this is Abubaker. I'm showing a video here of a patient that had perforated diverticulitis over a year ago, and she's been and this was complicated postoperatively with development of an abscess next to segment 7 of the liver. She's been treated with IR drainage at least 3 times, and she keeps getting reaccumulation of the abscess. She grew multi-resistant bacteria. So she was referred to me for drainage of the abscess. As you can see, there are a lot of adhesions here between the liver, the right liver lobe, and the diaphragm. So doing careful less of adhesion in these cases are perfect to do robotically. You can see a lot of spots there, and that's was mostly fat necrosis, but and she has no history of any cancer, but I still got a specimen sensitive to pathology, showed granuloma changes, or sorry, giant cell reaction. That was a small piece I was going to send, but I found other pieces that I ended up sending to pathology. I like using a Maryland in my left hand as like when you're doing open cases, like a right angle or a tonsil. Sometimes I wanted to be careful here during the surgery, especially at at the level of segment 7 of the liver. I didn't want to enter the chest, like burning the diaphragm or causing an injury to the diaphragm and having all that bad purulent bacteria-resistant material entering the chest. So it's just trying to kind of mobilize that right lobe of the liver as much as possible. That's a falciform, so the area that to the left of the falciform is segment 4 of the liver, or to the left of the screen, I meant. Right side of the falciform. So I know it was kind of located posteriorly, again, at the level of segment 7 of the liver. So I had to kind of dissect as much as possible, trying to tease off whatever will come off. Again, you have 3 IR drainage that will get it smaller, but will never disappear completely. And again, I do not want to enter the chest or make an opening the diaphragm and allow that pus to go into the chest, because that will be a problem. Using the ultrasound here, to locate where the abscess is exactly and how far I have to go. I'm going to increase the gain. Right there, you can see the abscess cavity. Moving forward with further lines of adhesion. The entire procedure was approximately an hour and a half. That's a rib there. You can see the right kidney. Another peek with the ultrasound. And it's right there where there's that adhesion there. Right there. So we're right on it. You can calculate with your ultrasound like how deep it is in millimeters to kind of give you an idea. Right there, you start seeing it right where those adhesions are. So I kind of know it's right there. As soon as I start taking those adhesions, that will be entering the abscess cavity. Quick camera clean here. Right there. Want to section as fast as possible. Did not want that pus to go anywhere else. But so the whole idea is that you want to open this cavity as much as possible, and you want to curette all of the opening, almost like you're doing any abscess are always like cavities. You want to break all the cavities and debride it until you can see some good blood. Careful here again, not to. Right there, the abscess cavity. We're entering the abscess cavity. Making sure your trajectory, you don't go full thickness into the chest, pleural cavity. And right here, I'm just breaking the cavities. Send some of that stuff for gram stain and culture. I grew the same stuff that I grew always, which is Pseudomonas that was multi-resistant to bacteria. Sorry, to many antibiotics. That's more pus there. So again, I'm moving using my instrument as a curette and the suction irrigator until you can see that nice blood. I'm just using both instruments to kind of curette the area. I think the suction irrigator works as a really nice curette. It suctions and you want to get it to the point where you can see some bleeding there. There's a adhesion there that I'm going to take down or attachment. Just taking all the cavities, and patient did very well. I was kept in the hospital for 3 days, and the reason behind that, actually, she was doing extremely well post update number 1, but the infectious disease wanted to have sensitivity before the patient can go home. Right there, just curating that area. I'm gonna break into that area again. You want to leave it wide open. Again, there's another small cavity there. Gonna open on top of it. and just debriding it. Once I do this, I'm going to repeat the ultrasound again to make sure that it's completely drained. Here I'm repeating the ultrasound again. I was trying to show this medical student like the middle hepatic vein. And the anatomy of the liver under ultrasound. Here again, you can't see any cavity left. It was well drained. Finally, I'm going to put a drain in there